Okay, so welcome to the next module. It's Dr. K here, and we're going to be talking about skin conditions, um, a bit of a review on classifying different skin disorders, and we're going to talk about some procedures to diagnose skin conditions. So, a bit of a mixed bag of an assortment of topics that we'll talk about in this module. I think it's interesting. Skin rashes are often a challenge, and often we have to resort to testing or biopsies to find out exactly what's happening with someone's skin rash. Okay, so but it is an interesting topic. Okay, so let's just talk about a couple of procedures and just some topics, just so you recognize what they are if they're mentioned, right? So what's a Woods light? Well, a Woods light is just a fluorescent light. Okay, so if we're looking at a skin rash and we can't really tell what it is, we can dim the lights in the room, put a fluorescent light on, which is called a Woods light, and it'll illuminate the rash for us. Okay. Dioscopy, this is just a way of distinguishing between um, a rash that's still in the blood vessels, so when you press it, it blanches, compared to a rash where the blood's outside of the blood vessels, such as a bruise or petechiae. Those are non-blanchable. So if you press your nail bed right now, it's going to blanch, and when you let it go, it's going to turn red again. That's because all the blood's in the blood vessels. If you have a bruise or a ecchymosis or a petechiae, well, that's blood that's leaked out of the blood vessels. It's non-blanchable. So that's all dioscopy means. In actual fact, we don't really use it. We just press our thumb into the rash. If it blanches and turns white, it means the blood is in the blood vessels still, such as in cellulitis. We press it, it blanches, and turns red as soon as we release it. Okay. I press a a large bruise. If I press that, it doesn't blanch. All that blood's in the tissue. Okay. Skin cultures and sensitivities. So we can culture the skin for almost anything. We can take swabs as long as we're getting a culture of the material that we want to test for. Because if you were to swab your skin right now, it would you would grow something likely, right? So skin has natural bacteria on it that's not causing a problem. So if we want to get a skin culture, say for a bacteria, we need to get into the pus of the wound and then send that off. We can also send a culture off for a virus. So say herpes. We don't often do this, but we can we can cut open the blister of herpes, put the swab inside, and then send it off to the lab to see if it shows the herpes simplex virus. Okay, the liquid from the blister. In terms of fungus, sure, we could do fungal scrapings of the skin, collect them, and send them off to the lab to see if they grow fungi. Okay, what's a tank smear? Well, that's just we take some liquid and we put it under a microscope, specifically looking for these large multinucleated cells that typically indicate a viral infection. That's it. So what's a tank sphere? That's hard to pronounce, by the way. A tank sphere is for viral infections of the skin. What's a KOH test? Potassium hydroxide test? Well, that's usually looking for fungus. So we're going to take some scrapings, put it in this liquid called potassium hydroxide, put it under the microscope, and see if we can see these filaments of fungus. That's it. Okay? We're going to talk more about medications for different skin infections. Remember, bacteria, antibiotics. And what kind of antibiotics? Well, if it's a superficial infection of the skin, such as impetigo, well, we can use superficial creams, right? So polysporin, mupirocin, those are for superficial bacterial infections. If it's a deeper infection, such as cellulitis, we're not going to get that with a cream, right? So they need oral antibiotics, such as penicillin or cephalexin. If someone has a severe allergy to penicillin, and we choose not to use a cephalosporin, such as cephalexin, because there's a bit of cross-reactivity, so we avoid them if someone has a severe penicillin allergy, then we can use a macrolide, such as erythromycin or azithromycin, or we could use a tetracycline. Okay? Skin biopsy is exactly what it says. I'm going to take a piece of this skin, send it off to the lab or pathology, and see what it looks like under the microscope for a diagnosis. So a punch biopsy, it's almost like we're using this little potato spud core, and we freeze the skin, and we take a punch biopsy. We put this little potato sputter into the skin and take a little sample of it, called a punch biopsy. A shave biopsy is where we just take a scalpel and shave off the surface of the rash and send that, or the lesion, and send that to the lab. So it's not removing the whole thing, right? So a punch biopsy and a shave biopsy, they're not removing the whole lesion. An excisional biopsy is when the decision is just, let's just remove the whole lesion. We think it's cancerous, let's just remove the whole thing and send it off to the lab. Okay. Okay, so MRSA skin infections, what are they? Well, they're just a bacterial infection of the skin. So they may present as cellulitis, which is a subcutaneous infection of the skin, right? And if the bacteria is MRSA, we'll call it a MRSA cellulitis. Okay. Now, MRSA, we focus a lot on this type of bacteria because it's resistant to many antibiotics. So our typical treatment with penicillin and cephalexin just don't respond when it's a MRSA infection of the skin. So that's why we typically have to resort to clindamycin, or if it's really severe and we need to use it intravenous, vancomycin. Okay. So think of MRSA as a contagious skin infection. Many other bacteria are contagious as well, that's resistant to many antibiotics. In fact, this particular skin infection can go through locker rooms. It goes through wrestling teams where many patients get it because there's a lot of skin contact. Okay, and that's partly why wrestlers are kind of banned from team competition when they have a rash. Okay, because it has to be cleared that it's not a skin infection. Okay, so how do we treat a MRSA skin infection? Well, we just use creams or antibiotics that we know are effective against MRSA. So if we're talking about a cream, because it's a small rash, a skin infection, we'll use something called mupirocin. It's just an antibiotic cream. If it's something that needs an oral antibiotic, because it's a bit more extensive, we'll use clindamycin, for example. If it's really extensive and the patient's sick, we can use IV vancomycin. In fact, patients with significant MRSA infections within the body, such as a MRSA pneumonia, we use IV vancomycin. If they have a MRSA infection in a joint, so septic arthritis, we'll use IV vancomycin. Okay? Cellulitis and erysipelas, I would just think of as basically the same thing, right? They're subcutaneous bacterial infections of the skin. Erysipelas is typically reserved for a cellulitis of the face, but really the same thing's happening, right? So we use oral antibiotics or IV antibiotics to treat these. Typically oral penicillin or an oral cephalosporin such as cephalexin. Okay? If someone has a severe allergy to penicillin or cephalexin, then we can get away from the penicillins and use an erythromycin, okay, a macrolide. So erythromycin, azithromycin, clarithromycin, those are all macrolides. Poison ivy, contact dermatitis, right? So you've come in contact with the plant. The resin of the plant has landed on your skin, and it's causing an inflammatory response, an allergic response that your body creates because of the resin. If you were to touch the resin and touch other parts of your body, you'll get the same reaction there. Okay? So typically poison ivy is itchy, it's blistering, it's red, and usually we use cortisone creams or even cortisone pills such as prednisone to settle it down. Okay? And also antihistamines. Spider bites, well, uh, any bite can cause a local reaction, so a local allergic reaction, swelling, itchiness, um, because of the foreign toxin that's gone into the skin. Okay, we can use antihistamines for that. It can cause a cellulitis because it punctured the skin, and we can use oral antibiotics for that. It can secrete a toxin into your bloodstream and make you systemically unwell. Okay, we'll concentrate on bees and wasps when we're talking about that. So a bee and wasp, same thing. It can cause a local allergic reaction where you have redness, swelling, itchiness to the site of puncture, or it can cause a systemic allergic reaction called anaphylaxis, right? So diffuse urticaria to your body, to your skin, um, swollen lips, swollen tongue, difficulty breathing from a tight airway, wheezing in the lungs, hypotension, tachycardia, confusion because of low blood pressure, nausea and vomiting can occur with anaphylaxis. Okay, so any of those symptoms, we're going to call it anaphylaxis. Snake bites, I'm not going to talk very much about. There's all kinds of snake bites. They can cause a local cellulitis, or they can cause a systemic illness because of the toxin that's made it into the bloodstream, right? And there's anti-venom um, drugs that are available to treat snake bites, right? So particular snakes, though. Actinic keratosis is a precancerous condition of the skin. So it's typically on sun-exposed areas of the skin, the forehead, the hands, the ears, the face, and it's a scaly, dry lesions that feel like sandpaper when you touch them. Those are precancerous. Okay? They have the potential to turn into basal cell or squamous cell carcinoma. Okay? So the three types of cancer: basal cell carcinoma, localized. It just grows locally. It doesn't metastasize anywhere. Squamous cell carcinoma grows locally, invades locally, but it has a small potential to metastasize. Melanoma, so malignant melanoma, can originate from a mole, a dysplastic mole, and then of course grow locally and metastasize to lymph nodes and distant organs. So that's by far the most serious cancer of the skin, right? Malignant melanoma. Skin cancer in general is the most common cancer that we get because of solar damage to the skin. Fluorouracil, when we're talking about the skin, it's basically a chemotherapy agent that comes in a cream that we can put on areas of actinic keratosis, sometimes on skin cancers, but most of the time on skin cancer, we just like to cut them out, removal, okay? Because then we know that we can send it to pathology and see exactly what kind of cancer it is. Okay, so just think of fluorouracil as a chemotherapy cream that we can put to treat actinic keratosis. It actually comes as a pill too for other cancerous conditions, but in this case, it's a cream for the skin. Psoriasis is an autoimmune disease that we're going to talk about, and these are some of the treatments that we use for psoriasis. So calcipotriene is just vitamin D, okay? Vitamin D in a cream. Coal tar is a messy substance that we used to apply to psoriasis. It would reduce the psoriatic plaques, but it's messy. Uh, we'll talk about tazarotene is a vitamin A analog. That's it. So it helps with the development of skin, and we use it on psoriasis because it controls the plaques and tends to reduce the level of the plaques. So it improves psoriasis. Steroid creams, those anti-inflammatory creams, yep, we definitely use those on psoriasis because it reduces the inflammation and shrinks the plaques. UV therapy is used on psoriasis. We know that patients do better in sunlight with psoriasis because of the UV therapy, so they can go for UV therapy um, as a medical treatment to treat their psoriasis. Stevens-Johnson syndrome, I'm sure you would have heard of it from now. It can be a severe skin reaction where there's blistering and breakdown of the skin and mucous membranes of the mouth, of the oral mucosa, the lips. The eyes become intensely red, and it can be from drugs that we use. An example would be a sulfa drug is a risk factor for Stevens-Johnson syndrome. And sometimes just a viral infection can trigger Stevens-Johnson syndrome. Okay, so it doesn't have to be from a drug, but we talk about it more in the setting of drugs because we administer medications to patients. Okay, now if it's extensive, well, we just call it by a different term. We call it toxic epidermal necrolysis, and we'll talk about that. And just see that as a severe form of Stevens-Johnson syndrome. That's it. Okay. When it involves more than 30% of the skin and the mucous membranes, we call it toxic epidermal necrolysis, TEN. Okay, so they're really similar. It's just the severity. So acne is a condition typically of teenagers, but of course it can continue on into adulthood. It's usually due to hormonal changes that affect the hair follicle and sebum production within the hair follicle of the face, the neck, and the back. And it's classically a rash that has pustules. Okay, so these white pustules on the face and back. Comedones, which are whiteheads and blackheads. You can get cysts with acne when it's severe, so cystic acne. It's a papular rash, meaning it's a raised rash. You can feel it if you ran your fingers over it. It's not macular, meaning flat. And there's a whole assortment of treatment for acne, whether it's creams, oral antibiotics, and if it's severe acne, if it's severe acne, called nodulocystic acne, we can use something called isotretinoin, okay, which is a very powerful oral medication that works extremely well on acne, but it has quite a few side effects that you'll hear about in pharmacology. Okay. Pressure ulcers. Well, pressure ulcers are very common in immobilized patients in bed, elderly patients that are immobile, post-surgical patients. And what are they caused from? Well, vascular compromise to the tissue because someone is lying on, say, their hip or their coccyx or their heels, and they're just not moving, and the blood supply is compromised to the tissue, and the tissue starts to break down. Okay. Okay, glucocorticoids, we'll talk about them, whether it's an oral glucocorticoid such as prednisone, an IV glucocorticoid such as methylprednisolone, or a cream such as hydrocortisone or betamethasone. So they come in creams, pills, and IV, and they're used for all kinds of inflammatory conditions. Okay, so if something's very localized in the skin, we'll use a cream. If something's more diffuse on the skin, and we can't get it with a cream, we'll use a pill. If something is severe and it's involving a large portion of the skin and the patient is systemically unwell, we may use an IV steroid. Okay? And there's a condition that we're going to talk about called psoriasis in this module, where sometimes it's so severe and it's an autoimmune disease that we'll use immunosuppressants to try and shut down this autoimmune disease called psoriasis. And these are just some of them that can be used. Azathioprine, methotrexate, cyclosporin. But just understand what you're doing. You're just suppressing the autoimmune system to shut down this plaque-like rash that's developing all over the body. Okay, so let's do the questions at the end of chapter 73. A nurse is caring for a client who has a suspected viral skin infection. Okay. Which of the following laboratory findings should the nurse expect to review to confirm this diagnosis? So a KOH preparation is for fungal infection, so A wouldn't be right. Diascopy is really just to see if the skin blanches when it's pressed on, to see if the blood is in blood vessels still and it's just inflammation, or it's actually blood outside of the blood vessels, such as a bruise, ecchymosis, or petechiae. So that's not going to do it. A tank spear is for viral infections. So C is going to be the answer. A biopsy, typically we're taking biopsies of tissue that we're going to send to pathology to see exactly what the skin condition is. So the answer here is C. Okay, so the next question, number 2. A nurse in a clinic is preparing to obtain a skin specimen from a client who has suspected herpes infection. So that's a blistering type rash that with fluid filled vesicles. Which of the following actions should the nurse take? Scrape the site with a wooden tongue depressor? No, you wouldn't do that. You could do that with a fungal, like a flaky fungal infection. But you're not going to scrape blisters. You're just going to break them open and lose the fluid, right? Use a razor to cut the scabbed area to obtain the specimen. So using a razor to cut the scabbed area, no, remember, herpes is a blistering rash. It has vesicles. So you want to open up one of those vesicles. So you're not going to use a razor to cut the scabbed area. Use a cotton-tipped application to obtain fluid from the lesion, meaning the vesicle. So C is right. Place specimen in a potassium hydroxide solution tube. Nope, that's for fungal infection. Looking for the filaments under the microscope. E, place specimen tube on ice after obtaining sample. Yes, I didn't mention that before, but for viral infections, once we get the sample, we'll place it on ice so that it stays prepared to then send it off for examination. Okay, so the answer is C and E. Number 3, a nurse is instructing a client on home care after a culture for bacterial infection and cellulitis. Which of the following information should the nurse include? Okay, so let's look at the answers here. A, bathe daily with a moisturizing soap. That's not going to help a bacterial infection. In particular, it's not going to help cellulitis because that's below the skin, right? It's subcutaneous. Apply antibacterial topical medication to the crusty exudate. That's not going to help cellulitis. Remember, it's below the skin. So that might help impetigo, not going to help cellulitis. Apply warm compresses to the affected area. Okay, could do that. Again, that's not going to help cellulitis. Oral or IV antibiotics are going to help cellulitis. So let's leave that one for now. Cover affected area with snug-fitting clothing. No, you wouldn't do that because you could impede blood supply to the area, which is what's bringing all the healing factors to the area. So I guess the only semi-right answer is C, apply warm compresses to the affected area. What's that going to do? It's going to increase blood supply to the area by vasodilation, and that could potentially help with healing. But I was kind of expecting a better answer than that, since cellulitis really needs an oral or IV antibiotic. Okay, so not a big fan of the answers here. Okay, so C. Number 4, a nurse is providing discharge instructions to a client who's had a skin biopsy with sutures. So they took the skin biopsy and then they closed it with primary intention with sutures. The nurse should identify that which of the following client statements indicates that the teaching has been effective. I can expect redness around the site for 5 to 7 days. No, not necessarily. Sometimes redness around the site can indicate cellulitis and infection forming. I will most likely have a fever for the first few days. No, you shouldn't have a fever at all. That's usually a good indication that there's an infection. I should apply an antibiotic ointment to the area. That's reasonable. You could apply a bit of polysporin to the area since it was biopsied and then stitched back together. A little polysporin wouldn't hurt, sorry. I will make a return appointment in 3 days to remove my sutures. No, typically sutures on the skin are about 10 days. Sutures on the face, they heal much faster, so typically 5 to 7 days. But the rest of the body, usually it's about around 10 days for suture removal. Okay. Number 5, a nurse is providing, the answer there is going to be C. Number 5, a nurse is providing teaching to a client about new prescription for clotrimazole. That's an antifungal. Which of the following statements should the nurse include? So, antifungal cream that you can buy over the counter. It reduces discomfort of a herpetic infection. No, that's viral. This is a cream to treat bacterial infection. No, treats fungal infections. Apply the topical medication for up to 2 weeks after the fungal lesions are gone. Sure, right? You want to get rid of the fungal infection, and sometimes just to prevent it from returning, it's applied for even longer. So C is the most reasonable here so far. D, apply the cream to lesions while they are moist. Now, you don't really want moisture with fungal infections. Fungus loves to grow in moisture. And then on top of that, if they're moist, the cream's not going to get to the skin as effectively. Okay, so the answer is C.